One of the techniques that I used to evaluate my patient was the ease to bind technique. With flat hands, bilaterally apply enough pressure to move the skin with the whole hand. Gentle movements in every direction elicit motion and tension quality of the fascia. Then this next video kind of just shows how this would look from the top. Next, I used the friction rub technique. Make quick strokes down the paraspinals and notice redness indicating vasomotor changes in areas of dysfunction. Finally, I used the spring test and thoracic PA glides to evaluate the intersegmental and segmental motion of the spine. Start by palpating to find the spinous process of the segment you want to mobilize. For the spring test, the pressure should be applied between the spinous processes of the vertebral unit, and for the PA glides, apply the force directly on the spinous process. I like to use my thumb and index finger to create a little beak that fits right over the spinous process. I position my shoulders over the segment that I want to mobilize, and I use my whole body to glide the segment anteriorly. You will notice a decrease in motion if there's a restriction. And again, here I'm focusing on the middle thoracic region since this is where I found most of her fascial restrictions. For a cervical manipulation, I have the patient lay supine and hold her head off the edge of the table. As you hold their head, remind the patient to stay relaxed and put their full weight in your hands. The first motion is side flexion until C5 begins to move. Then add extension until it moves again, still maintaining the side flexion. Carefully rotate the head opposite from the side bend until the restrictive barrier is completely engaged. Without recoil, thrust the head quickly past the barrier. For a thoracic manipulation, I have the patient lay supine and cross her arms over her chest. I use one hand to lift her up and place the thenar eminence of my other hand directly on the segment that will be targeted. I roll the patient back over my hand and use my other arm to pull her into flexion until I can feel the segment move on my bottom hand. As the patient takes deep breaths, I can take up the slack until the restrictive barrier is engaged. Without recoil, thrust directly down over the targeted segment through your bottom hand. Lumbar manipulation, I have the patient lay on their side facing me. I rotate her by grabbing her bottom arm and lifting it up until restriction. Then I palpate the segment I want to target and flex her top leg until that segment moves. Here I can lock her foot in behind her leg. I slide one of my arms through hers and place my other arm and hand over the segment that I'm mobilizing. Place my knee on top of her bent leg to use as a lever for my thrust. As the patient takes deep breaths, I can take up the slack until the restrictive barrier is engaged. Without recoil, thrust in a direction towards you, focusing on applying most of the force through the hand over the lumbar spine. The cross hand release is a type of myofascial release technique that focuses on the distraction or separation of the tissues. The thenar eminence of one hand is placed with the fingers pointed towards the head, and the thenar eminence of the other hand is placed below it with fingers pointed towards the feet. The targeted tissue or area of restriction should be between the hands. My arms are now in a cross position and I can begin to exert a force anteriorly to engage layers of tissue and then in the direction of the fingers on each hand to create the distraction effect. This technique can be performed with a gentle, rhythmic, and kneading stroke as I'm showing here. I'm actually working right over that thoracic restriction, trying to create a separation in the tissues. The cross-hand release can also be applied statically, where the pressure is deep and sustained. Typically, if this technique is effective, it will feel like your hands are sliding apart, even though they aren't actually sliding on the skin. Tissue rolling is another type of myofascial release technique that is especially good for superficial restrictions. It can be done in all directions across the tissue. First, grasp and lift the skin, trying to only grab superficial layers. Your fingers should look like you are pinching the skin in a roll. I keep the skin lifted between my fingers and slowly start to walk my fingers away from my body as my thumbs push into my fingers. This should create a smooth, continuous roll over the skin, going away from you. When you come across a restriction, the skin will not lift or roll smoothly, and it can be very painful for the patient. When I found a restriction on my patient, I stayed on it and oscillated the roll back and forth, trying to free it up. Trigger points are hyperirritable spots in a muscle that are usually very tender. They are palpable and can be easily found when evaluating tissues for restrictions. They prevent full lengthening of muscles and can also weaken them. To release a trigger point, direct pressure is applied into the palpable tender spot for about 90 to 120 seconds, or until you feel the knot melt, soften, or in other words, release underneath your finger. I will start by placing her right hand on her left shoulder, and then I will place my left forearm underneath hers, grabbing her right shoulder on the other side. I palpate for T4 or T5 and then let the patient's head rest with full weight on her arm. I slowly raise my left arm while gently translating the vertebra forward to the extension barrier. Using the space between my left arm and my body, I can push her left shoulder down to engage the side bending barrier. When I rotate my body, it should rotate the patient's shoulder with me to engage the left rotation barrier. Holding her in this position, I will then ask her to push her elbow and forehead down against my arm and turn to the right. She will hold the contraction for 3 to 5 seconds and then relax. I can now move her once again into the next barrier. This is repeated about 3 to 5 times or until the motion is maximally improved. The first step in the strain-counter-strain technique is to find a point along the muscle that is the most restricting or bothersome. Once I find the point, I ask the patient to rate the pain on a scale of 1 to 10. I place my forearm under her axilla on the same side as the tender point, with my hand on the posterolateral chest wall. Using my free hand, I apply pressure to her tender point again and slowly begin to lift my forearm to create extension and some rotation. During this time, I'm asking for patient feedback. She lets me know at what point her pain is slightly alleviated. Make sure to go through the full range of motion slowly so that the patient is able to find and focus on the exact position that feels the best. Once the most comfortable position is set with that motion, I no longer move her arm into extension or rotation. This time, I use my forearm and shift my body to bring her into shoulder abduction and adduction. Again, I find the best position being sure that I went through the full range of motion slowly to find the position where she feels the most alleviated with abduction and adduction. Once I find both comfortable spots, I hold this position for 90 seconds, continuing to apply the same amount of pressure. When I'm finished, I bring the arm back to a neutral position slowly, first coming out of abduction or adduction, then coming out of rotation and extension, while continuing to apply the pressure. I slowly release the pressure, give it a few seconds, and then push the tender point again. I then ask the patient to rate her pain once more. If the rating significantly decreased, the restriction will either be way less of a bother or completely gone. Feel free to yell, "Freedom! Freedom! Freedom! Give what you say.